We have seen earlier various actions of adrenergic and what are various places they are there. Now, what are various places on which drugs can act? We have seen all these places. We were seeing about few more things, that is, what are the preponderances or where the receptors are more, which receptors are more prominent. They have faster in action, some are in slower in action, and on that basis we can have different action. Yesterday we have seen how a single type of agents, means all are adrenergic agents, and only because of their different in the affinity with alpha beta, how the actions can differ. We have seen it with the example of changes in the blood pressure because of adrenaline, noradrenaline, and isoprenaline, and we have seen that how the impact can be there. Okay, then we have also tried to understand the importance of the reflex mechanism, how the reflex mechanism works and how they play important role. A few more important things are there. One of the very common and very important experiments which were carried in almost in earlier century, in previous century, rather it's rather in 18th century, I can say, in 19th century, means before 1900. The researcher was Dale, Henry Dale. You know Rang and Dale, you might have studied. So from that Dale was there, and he has found in 1920 or around 1920 after he has found it that he tried to put on the experiment of blood pressure, and when he has given adrenaline, he found the response which we have seen earlier. That means there is increase in systolic blood pressure and decrease in the diastolic blood pressure. So we have attributed it, but then he made the research of it. We have now we understood, and we can say that it is happening because of this. What we have seen, that why this is happening. Yesterday we have seen this. Why this is happening? Why there is increase in systolic blood pressure and why there is a decrease in diastolic blood pressure? Anybody? Okay, increases because of beta. Very good. So increases because of beta 1 only or any other reason? Because adrenaline has got affinity with which receptors? Yes, alpha 1. If it is acting on alpha 1, then what will be the action? So Dale has studied one thing. Dale has studied one thing, that he has given adrenaline, he checked the response. Then what he did is he gave the alpha 1 receptor block. So when no drug was given, only adrenaline was given, there was overall increase in the blood pressure. There was overall increase in the blood pressure. Why it was overall increase in the blood pressure? Because alpha 1 effect, beta 1 effect, which were stronger than beta 2 effect. Okay, particularly alpha 1 is coming first, therefore the beta 2 could not be seen, or there was a very little change in the diastolic blood pressure or decrease. When he gave the alpha 1 blocker, when the alpha 1 blocker was given, because of alpha 1 blocker, there was, he could find the decrease in blood pressure only, because alpha 1 vasoconstriction was not there and beta 2 mediated vasodilation was there. It was more comparatively. So because of the beta 2 mediated vasodilation, there was only fall in blood pressure. Okay. So the same adrenaline, when given along with the alpha 1 blocker, shows the decrease in blood pressure. Okay, and without alpha 1, it shows the increase in blood pressure. So, this is the reverse of the action. This is the reversal, that is therefore called as a Dale's vasomotor reversal. This was a very important study to indicate that adrenaline can act on both type of receptor, alpha 1 receptor as well as beta receptor or beta 2 receptors. Okay, so this is how this science is evolved. Many times the question is asked, what do you mean by Dale's vasomotor reversal? It is easy question. If somebody want, it can twist it. Okay, that why, what is the sequence of the action, what happens first. That indicates that the alpha receptors are prominent. Therefore, adrenaline binds alpha receptor plus and show the alpha 1 mediated action first, which is comparatively stronger than beta 2 mediated one. So this is very clear indications that when we say about the preponderance, then the affinity with the receptor that differs. This gives very good examples of that. That it shows that alpha 1 are predominant. Okay, then adrenaline in blood vessels, that means alpha 1 have more role comparatively than beta 2. They are more in number or they are more having more activity is one thing. Second thing is that indicates that adrenaline has first binding with alpha 1, that means preferential binding with alpha 1, and then it binds to beta 2 is second understanding we get from that. And because of that, if there is no alpha blocker, it will show, then only it will show the beta 2 activity. Otherwise, it will not show beta 2 activity, or it is so little that it is not recognized, it is not identified. But when we block the alpha 1 receptors, then with antagonists, then we will understand that what is the action. This you understood what is called as a Dale's vasomotor reversal. Understood the concept? Similarly, we have seen such example with reserpine. That reserpine causes the chemical depletion of neurotransmitter because it will not allow the neurotransmitter to go inside the vesicles, and therefore it will remain outside. If it remains outside, it will be subjected to the metabolism by Mao enzyme. Now, if that reserpine, because of reserpine, if reserpine is given for some period of time, slowly, initially it will show adrenergic activity because more free drug is present in synapse. But slowly, with time, it will cause depletion of adrenaline, noradrenaline, and because of this is called as a chemical depletion. Okay, or a sort of action that is because of the chemical denervation is one more word is used, that is chemical denervation. Denervation means removal of nerve. You understood this term, chemical denervation or neurotransmitter depletion. So reserpine is causing this kind of depletion. Similarly, uptake inhibitors, because uptake, we have seen various neuronal uptake inhibitors. Okay, so this uptake is there. Out of that, around 70% drug comes as uptake. So that uptake is inhibitor, then it will also cause neuronal depletion. But before that, initially it will cause what? Initially it will cause increase in the concentration in the synapse. Whether it is reserpine, which blocks vesicular transmission, or whether it is because of the drugs like vanitidine, etc., which are causing the blockage of uptake. So, because of this uptake inhibition, or because of this, initially the synaptic concentration will increase for some time, and later, since the recycling of neurotransmitter is not possible, it will not be put into vesicle. If it is not into vesicle, then whenever the impulse will come, because of the whenever impulse will come, calcium ion will be coming inside, and when calcium ion is coming inside, because of calcium ion which is coming inside, there is exocytosis of the vesicle. So this exocytosis of vesicle will also take place, but there is no neurotransmitter in that. And this type of phenomena we call it as a chemical depletion or chemical denervation. Denervation means, the meaning of denervation is what? Removal of the nerve. Okay. So chemical denervation means nerve is not removed, but the nerve will not function or will not able to release neurotransmitter as it happens in the removal of nerve. If some nerve is removed, then there will be no neurotransmitter release because nerve is not there. Similarly, there will be no neurotransmitter release, and this type of thing we call it as a chemical denervation. You understood the concept chemical denervation, what it is? Okay. See, these are the important concepts. I told one thing about what Dale's vasomotor reversal, their reason. Second is what is chemical denervation. Okay. Now, what will happen because of chemical denervation is whenever this type of chemical denervation is there, the postsynaptic receptors are there more activated. They are more activated, and because of that, we call it as upregulation of this. Because there is a no neurotransmitter, so they will be becoming very active. Now, what happens is if somebody gives MAO inhibitor simultaneously with reserpine, now what will happen? The problem with reserpine was not because of reserpine alone. The problem was it was not allowing to go into vesicle. Because of that, it was increasing the concentration in the cytoplasm of the presynaptic neuron. But the problem is what? But whatsoever free is there, which is available over there, that will be metabolized by the inhibition of that will be metabolized by the enzyme monoamine oxidase. So this monoamine oxidase, if we inhibit, immediately we shall see the action which is called as a reserpine reversal. Okay, which will be opposite to the reserpine. Reserpine will cause decrease in the blood pressure because all sympatholytic action it will be showing, because it is not allowing noradrenaline to be released. So whatsoever happen, if the noradrenaline is not released, so decrease in the heart rate, then decrease in the force of contraction of heart, then all the actions which we have seen with adrenergic mechanism. Because of alpha 1, there is no adrenaline for alpha 1, so no vasoconstriction, and that means the vessels will be remain dilated. So these are all actions that will be seen because of the reserpine. So reserpine was earlier used in the treatment of hypertension when other drugs were not there, but it shows what's your adverse effects there are no. And second thing is it causes if by chance by mistake somebody gives MAO inhibitor, then this MAO inhibitors will cause the reserpine reversal. You understood? First thing is Dale's vasomotor reversal, which is different. Reserpine reversal is because of the MAO inhibitors. Third one is their tyramine-like agents. Okay, they are acting as a false neuro. They are acting as a what we can say competitor for the channel. We have seen the indirect action agents. This tyramine is not having action, but tyramine causes the feedback release, whatsoever is their uptake is there, where that will be inhibited, and thus it increases the concentration of neurotransmitter in the synapse. Now, again, this is also metabolized by the MAO, and therefore, whenever tyramine is there and MAO is there, so there is a reversal of the MAO inhibition, and therefore the actions will be seen more. And this type of reaction they are called as a cheese reaction because tyramine is abundantly present in cheese and chocolates. So when chocolates or cheese-like things are given, when MAO inhibitors are given, that will cause a total opposing reaction from the MAO. Whatsoever action MAO was showing, opposite to that will be seen. Okay, so this is another thing that is called as a reversal of the action. These three things understood, these are the basic concepts. You understood all this? Any difficulty in this? I repeat the names. If you have not taken down, you take it down. One I told about Dale's vasomotor reversal. Second thing I told about the reserpine reversal when it is combined with MAO inhibitors. Third one is the cheese reaction of the tyramine. Okay, you just remember this. These are easy to understand. There is no much difficulty. Okay, if any difficulty while reading you encounter, then you put on the group. We shall try to solve it. Okay, but keep on reading it. Then we shall see what are the various drugs. We have seen directly and indirectly acting, and some of the drugs we shall study in more detail when we shall study different topics or chapters. So I am using again table from Rang and Day, which is easy to explain. So first is noradrenaline or norepinephrine. We know what are the action. It is action on both alpha as well as beta. It is sometimes used for hypotension in intensive care, particularly when you are in go to hospital, you will understand about it. Noradrenaline is very popularly, or norepinephrine is very popularly given in the condition of shock. It is called as it when it is hypotensive shock. So to increase the heart rate and to increase the blood pressure, this drug is used. If it is used for hypertension, that means it can cause hypertension. So, what are the adverse effects? It can cause hypertension, vasoconstriction, tachycardia, or reflex bradycardia. Now, I hope you understood why reflex bradycardia. We have explained it. What is reflex bradycardia here? Reflex bradycardia means the drug will cause tachycardia, but because of the baroreceptors which are present, they will sense it, they will send the information to cardiovascular center, and cardiovascular center will cause slowing down of the heart rate. We call it as a reflex action. So it is a action because of the reflex mechanism initiated by body, and it is not drug's own action, and many times it can be opposite action to the drug. Why it is? Because body is trying to compensate it. Okay, so this is what reflex bradycardia, ventricular dysarrhythmias, because increase in the heart rate. So it has to be given by only parenteral, it cannot be absorbed by oral route. Then next is adrenaline. We know again it is alpha beta direct agonist. It is used in emergency treatment in asthma, in anaphylactic shock. Is very famous for anaphylactic shock, because if you remember, we have seen one word. It is physiological antagonist. Actually, there is nothing like physiological antagonist, but basically this is also agonist. Histamine is also agonist. It has exactly opposite action to histamine. Histamine causes bronchoconstriction, vasodilation. It causes vasoconstriction, bronchodilation. And therefore, when there is too much histamine release, we use agent which is having opposite action to that. Okay, this is also given by parental route only. Then next is isoprenaline, but it is non-selective beta agonist, means it can act on beta 1, beta 2, beta 3. It is not acting on alpha, so we are not able to see any alpha action. So it is used in, it was rather initially used in asthma. This word you can encounter many times. OBSOLETE, obsolete. Obsolete means now it is not used, it is out of use. Okay, it is very old, it is long back it was used, but now its use is obsolete. It is not absolute. Okay, so you should understand this word obsolete. Obsolete means it is of no use now, it is not put into therapeutics for this purpose. अस्थमा के लिए isoprenaline is not recommended, so it has become obsolete, it has become old. Just like your mobile technology or other technologies, they become old and useless. So similarly, this is old and useless. So we call it as obsolete. So effect are tachycardia, etc. In asthma, we have got better drugs, so we do not use them. We shall study when we shall see, or when you will study in respiratory diseases. At that time, we shall see various beta 2 acting agents, okay, where they are. Then next is specific agonist, that is dobutamine, which is acting on beta 1. It is non-selective also, but more towards beta 1. It is used in cardiogenic shock. Cardiogenic shock means where cardiac output has reduced too much, heart rate has reduced too much, force of conduction is reduced too much. Okay, this is a very severe condition where heart can stop at any time. It is sort of last measure it is taken and it's given we shall study when we shall study cardiovascular system in detail. But you should understand the mechanism that it is selectively beta 1 agonist. Then next is salbutamol, salmeterol, terbinafine. Then all these are the agents. They are acting on beta 2. Okay. So these are used particularly in bronchial asthma. We shall study when we shall study all these drugs in drugs acting in respiratory system. But we should understand. Then we shall not study all the mechanism because we know the mechanism. Okay, mechanism is what? They all are beta 2 agonists and they are specifically acting in or they are specifically more uh, active for the bronchial beta 2 receptor. So it will show bronchial beta 2 activation. Because of beta 2 it will cause bronchodilation, and which is very important treatment in bronchial asthma. So these are many drugs which are present in this agent. Then next is mirabegron. This is also beta 2 agonist, but it has got more activity in urinary bladder. So we have drug which is acting in urinary bladder, and when the bladder is overactive bladder, in that case we can use adverse effect can be tachycardia because of the some of the beta 1 activity. So it will show tachycardia. Same is the case with the salbutamol. It can cause tachycardia, dysarrhythmias, then peripheral vasodilation. Why it will cause? Because simultaneously vasodilation because of the beta 2, tachycardia because of the some of the beta 1 action. So although it is specific, still some action will be continued. Okay, so this is why this is how these drugs are there. Then next is phenylephrine. We have started yesterday. I asked you the what will be the actions. So alpha 1 agonist, it is used in the nasal decongestant. If you know about many Vicks like Vicks 500 and all these remedies, for that in that these drugs are there, phenylephrine etc. They are for nasal decongestant. The mechanism is what that it will cause vasoconstriction in the nasal area, and because of the vasoconstriction, the secretions will be less because if it is vasodilation, more supply to gland and gland will cause more secretion. So to decrease the nasal secretion, this phenylephrine is used. What are the adverse effects? Because of alpha 1, alpha 1 is present in blood vessels, so it will cause hypertension. It will cause reflex bradycardia. I hope you remember yesterday we had a discussion about it. Why it is reflex bradycardia? Okay, because of the cardiovascular center receiving response from the baroreceptor. Okay. Then next is other agent which is methoxamine, which is also an alpha agonist. It can also be used as a nasal decongestant similar to phenylephrine. Then next drug is clonidine. So clonidine is alpha 2 agonist. It is used in the treatment of migraine and hypertension. It causes drowsiness, orthostatic hypotension, edema, weight gain, etc. Now, this all we shall study when we shall study drugs acting as an antihypertensive. So, when we shall study about that. So, basically, I wanted to tell you about the drugs which are there, and all these drugs they are have all these agents which are acting. They are active at one or other places. There are many places where the drugs are acting. We have seen earlier where the drugs are acting. So they are important in central nervous system. They are important in peripheral nervous system. There are many drugs which are acting by one or other mechanism. All this mechanism like uptake inhibition, we shall study when we shall study drugs acting for depression. Okay, so there are many places where this adrenergic noradrenaline are working. So if you read it good, if you try to understand all the basics, then it will help you to understand other neurotransmitters also. As I told you earlier, it will help you to understand about dopaminergic system, just like adrenergic, cholinergic. We have got dopaminergic, serotonergic, and many other such system. So basically, most of the things, mechanisms are common except their receptor, their modulation. but synthesis like thing only some synthesizing enzymes, and the substrate will be different, but many things are same. Similarly, we can find there are uptakes, we can find that there are controls, there are autoreceptors. So these all words, what are autoreceptors, what are controls, what are the direct release of the drug through the pore, okay, maintaining equilibrium. So all these things, with maybe very small changes will be there. And because of that, once you understand this cholinergic and adrenergic system well, how it functions, then other for other system, only the changes you have to remember, but basic you will be knowing that what are these things. Okay, so read it thoroughly. We shall see one more table which shows the places of action. I think I'll, sh- I'll show you the various places of action where the cholinergic and adrenergic drugs they can act or they can have, and this will make you very clear about the things that there are how many places we have these agents to be there, and how it will be important for various activities. So once we understand this, it will become very easy for you to go for the what's your topics are there up to that. Whenever we go for these topics, may it be central nervous system, may it be peripheral nervous system, and what are the effects these drugs are showing. So I'm repeating this as such. We have discussed this when we have studied this varicosity. If you remember, isn't it varicosity of cholinergic and varicosity of adrenergic? At this place, we have seen various agents which are acting, and because of their action, we can say that there are many agents will be available for one or other actions. So this varicosity, you please go through well, varicosity of cholinergic neuron and adrenergic neuron. So it will indicate you how the drugs are there, how the drugs are acting, and because of this, how this system works, and what are the places where we can have various drugs which are particularly working at one or other level. So let us see what are the basic mechanisms are there and what kind of drugs and effects we can see both cholinergic and adrenergic. I am just revising for your ease. So first one is mechanism, basic mechanism is interference of synthesis of transmitter. Okay, that we have seen. If it is acetylcholine, that it is acetylated, and choline plus acetylation that becomes acetylcholine. So it is a biosynthesis. In adrenaline, we have seen from tyrosine, various tyrosine, dopa, dopamine, these are the steps. Okay. Now, what will be the agents acting? So there are agents. Example of this, there is a choline acetyl transferase inhibitors. They will cause minimal depletion of ACH. Why there is a minimal depletion? Because ACH is again basically taken back, so there will be minimal depletion. But if it is adrenergic, there is alpha methyl tyrosine, and because of alpha methyl tyrosine, it causes depletion of noradrenaline. So wherever there is a hypertension or wherever the conditions where there is a more activity of noradrenaline or adrenergic activity is there, that drug can be active. Then metabolic transformation by same pathway as the precursor transmitter. Example is adrenergic, in that methyl dopa is drug. This drug we shall study when we shall study antihypertensive. So what it is doing? This methyl dopa will compete for the dopa, and thus dopa to dopamine and noradrenaline it is formed. Similarly, it will become methyl noradrenaline. Instead of simple noradrenaline, it will become methyl noradrenaline, and it is actually acting as alpha 2 agonist. So as it is acting as alpha 2 agonist, it will cause its own release, decrease in the release of adrenaline, and thus it will acting as an anti-adrenergic or adrenolytic agent. Okay, so it will reduce the sympathetic outflow from the CNS. Then next type of action is there to what we call as a blockade of transport system. Sorry, blockade of transport system at the nerve terminal membrane. Okay, at membrane the transport is blocked. Example we have seen hemicolinium, cocaine, imipramine. Okay, imipramine is an antidepressant drug, so we shall study. We call it as a uptake inhibitors or NET inhibitors, neuronal uptake or neuronal noradrenaline this taken back. So NET type of transporters are there. So in adrenergic, cocaine, imipramine, they are causing accumulation of NE, noradrenaline at the receptor. But if it is at higher doses, that can also cause further depletion. Okay, if it's then next is hemicolia. In case of cholinergic, it blocks cholinergic uptake with consequent depletion of ACH. So here also cocaine and imipramine are not that stronger, so they may not cause depletion. But if it is used for higher doses, then they may cause depletion. So this is a dual action. At low dose, for small duration, it is increasing the action of adrenaline. And if it is used for long period of time, even same thing with the reserpine. Okay, so it will cause same action. Then next is the blockade of transport system of storage vesicle. If you remember in acetylcholine also there is a storage, in adrenaline also storage, and there are agents which block the storage. In cholinergic it is besamicol, it blocks ACH storage. In adrenergic, reserpine blocks the vesicular storage, and because of that what happens that mitochondrial MAO will cause the destruction of it, and it will result into depletion of the noradrenaline or adrenaline from the terminal, so it will not able to secrete. So reserpine is initially acting as a adrenergic at low doses because it increases the concentration, but slowly after some time at higher doses it is causing depletion of neurotransmitter, and we have used the term what? We use the term that is chemical denervation. We have used this term. Okay? So this is very important. Then there is one process of promotion of exocytosis or displacement of transmitter from storage site. In cholinergic, there are toxins are there, mangarotoxins and other toxins, example latrotoxin. So initially they will be cholinomimetic because it will initially allow, but then later it will be anticholinergic agents. Then adrenergic, amphetamine, tyramine, they are the agents, they are sympathomimetic because they causes exocytosis or displacement of neurotransmitter from the storage sites. Then next type of mechanism is prevention of release of transmitter. That is, the neurotransmitter is prevented. Okay. So this example is again botulinum toxin or Botox it is called as, and it will show the anticholinergic action. It will prevent skeletal muscle contraction. So where the person are having more muscle contraction. Example, we have seen the disease when we were seeing entrophonium, if you remember. Excessive muscle contraction was there in what condition? In Huntington's chorea, because myasthenia gravis is having less contraction. Then next is adrenergic release transmitter. See, for that, I repeat, for all actions, you have to keep this varicosity figure in front of you. That varicosity figure, if you remember, that how the synthesis and neurotransmitter is doing. So, in that figure, all these steps you put in, and when you put all these steps one by one, at every this picture will be clear to you. So, anti-adrenergic is bretillium, 100. These are they are preventing the release of neurotransmitter. Then the drugs which are having either agonistic or antagonistic action, that is mimicry of transmitter at post-junctional sites. Okay, so these are in cholinergic, we know muscarinic agonist, nicotinic agonist, mixed agonist, or which are common agonists. In adrenergic, alpha 1, alpha 2, beta 1, beta 2, or alpha 1 and alpha 2 both, alpha 1 specific, alpha 2 specific, alpha 1 and alpha 2 is alpha specific, beta 1 specific, beta 2 specific, beta 1, beta 2 specific. So these are the agonists, and again we have got antagonist on all these receptors. So this is one way. Then last one is inhibition of enzymatic breakdown of neurotransmitters. We have seen cholinergic acetylcholinesterase inhibitors. We have seen the effect of this, example of this where atophonium, neostigmin, pyridoxine, etc. So all these will show cholinomimetic actions at muscarinic as well as nicotinic sites. In adrenergic, there are various agents, example non-selective MAO inhibitors. We shall study them when we shall study various diseases. This we will study in detail. So example of these is they have little effect on noradrenaline and sympathetic, but they have caused increase or potentiation of tyramine. I told you today about cheese reaction if you remember. So this is very important about this. Then selective MAO-B inhibitors, example of this is celagerin. It is used in Parkinsonism disease. Then COMT inhibitor, okay, that is entacapone or dolcapone, they are used in Parkinsonism disease. So this simple one table gives you whole pharmacology of ANS. Okay, what you have to do is you have to keep that adrenergic and cholinergic varicosity picture in front of you. And then now once you understand this table, once you understand this, once you understand that which receptor are prominent at what place, your most of the actions, most of the things are you have remembered. Anybody, if somebody asks you in the midnight at maybe you are in deep sleep and ask you what will happen because of that, you will able to tell this is happening. Because this is if logically you go, it is very easy. If somebody tries to mug it up, then it is difficult. Then it is not possible to remember so many number of drugs and so many number of things. So one by one, step by step, logical way, if you go, it will be helpful to you. I hope you understood this thing. We are increasing slowly complexity so that it is not becoming too complex for you. Okay, so what you will do now in next 2 days, you will revise what you have studied in this week is one thing, and second thing you will go for all the drugs pharmacology, all the agonist and antagonist. You will find that they are basically same. Okay, only one or other drug is having changes because of either pharmacokinetic or some additional activity the drug is having. Okay, that you have to remember. So go for all the various agonists of cholinergic, antagonist of cholinergic. Once you study this, then next week we shall be going for the other effects of cholinergic. In next week, our job will be cholinergic agents in myasthenia gravis, cholinergic agent as a skeletal muscle relaxants. These are all nicotinic action related activities. So once you go through this, your basics are clear. We can do it with better understanding for you. So I think everything is clear. Any difficulties?